Hey guys, it's Dr. Greer. I just realized I don't have my AirPods in, so let me know if you can't hear well, but I think you should be able to hear just fine. Dr. Gallus will be joining me momentarily from San Diego. I see her. We just have to bring her on. As soon as I find her, there we go. And then we'll get her joined and we'll start talking. Hey!
Hey, good to see you.
How are ya?
I'm good. A little confusion at my house right before I got on here about who has volleyball when and ballet and
Because moms are the managers of the houses.
I know. Well, my husband he was like freaking out about what time he needed to leave to get everybody at their places. And then it turns out I go upstairs to talk to the 14-year-old. She's like, I don't even have volleyball.
Yeah, you're like, peace, have fun, figure it out.
Okay. Problem solved. Crisis averted. We're okay.
Yay.
Yay.
So welcome to our new night. We're doing Monday night now because my kids are with their dad on Monday. So you will not be getting photobombed by angry children repeatedly. Sorry, guys.
People have something in their nose. Yeah. I cannot.
Or they come and they whisper. They're like, I stuck popcorn in my ear. Awesome. Can we maybe not do that during the Instagram live?
Yeah. So yes, our focused, unfettered attention, maybe. Maybe my goodness. I have a brow story since our last conversation was about brows just today. One of the doctor who office shares with me and does injectables had a patient who had tattooed her brows because we were talking about that, the microblading and doing, but she didn't like where they were, so she sort of went up, so as if you did them like a whole, like, I mean, when you look at her, you don't think, oh, those brows are really high. Not at all. But when she animates and moves, which I don't know why I can barely animate because I'm Botox, but anyway, the muscle bulge is like below her eyebrow.
Oh.
So she wanted her to Botox below the eyebrow, which, normally we don't do because you're worried about dropping the eyelid. But in this case, it's probably okay because you're still hitting the anatomic muscle, not just because the eyebrow.
It's not actually below the eyebrow. Yeah. Okay. I mean, yeah, the whole corrugator would be like, right. Wow, those must have been really high up. Or
they're really high. Yeah. I don't know how that's going to go over time.
Interesting. Yeah, because the muscle we're talking about, guys, is right here, which I would frown, but I can't. But it's here. So her eyebrows like jumped up a centimeter.
Yeah.
Legit.
I mean, I did that once for Halloween. I was the Red Queen. And I powdered my face. Like you make them disappear and then redraw them like way up on your forehead. Anyway, bananas. It was not a good look for me personally.
No, I think you would look pretty dramatic.
Insane. Yeah, I looked insane. So, all right. Well, but we were going to talk about breast surgery and
labiaplasty.
Oh no, you're right. Labiaplasty. Never mind.
Yeah,
you're correct.
I don't think we've talked about that one yet.
We have not. So, yeah, popular procedure.
Yes, very. I am doing more and more of them. And we just want to reassure you guys. Sorry, my left eye blinks slower if you haven't noticed. Only on camera though, it's weird. I think every patient who comes in for labiaplasty feels like they're the only person in the world. And like, nope, there's just a really wide variety of normal labial anatomy, and that's totally fine. The issue is when people are uncomfortable or there's chafing, or sometimes you can't wear yoga pants without deciding on a side, which is not comfortable.
Right.
Yeah,
I agree. I think everyone feels almost a little embarrassed to come in for it, but once they do, and if it is, a lot of times it's anatomically inconvenient. It ends up, and I think if you have excess labia minora, since if you have it to the point where it's getting pulled on or it's just a little bit longer than you want it to be, and so it ends up getting trapped in clothing, or when you're playing sports, it this phenomenon of it getting tugged and stretched actually makes it longer. So I know there's a discussion about like, it's not an aging thing per se. It can come from weight loss. It can come from childbearing. It can come from aging, and it can just be how you are. So
it can be one side. It's not always both.
Yeah. Some of my most satisfied patients are the ones where they just have two sides. One side's totally normal, and the other side's like way out there. And they're like, this is making me insane. Can you fix this? Absolutely. And I can match it to the exactly to the other side. Like, it's so easy.
And when people, I know some people get really, I don't know if miffed is the word, but maybe offended. Like there's nothing wrong with people. Why are you altering this? In terms of invasiveness, it's like we're taking off a bit of skin. It's not, we're not touching any of the deep nerves. We're not touching any of the deep tissue. It's just like a little nip and tuck, kind of like an upper eyelid blepharoplasty. It's a little pinch of skin. So it's not invasive. It's not a high risk procedure. And generally the comfort level afterward is dramatically increased. And a lot of people feel a lot less self-conscious too. So it's a lot of positives with very little downside. Don't confuse this with anything like female circumcision or anything on that level. It's just like a little nip tuck.
Right. I agree. There are some people who are, but just like with any plastic surgery procedure, like, why can't you be happy with the way you are? Well, if this is your issue, that's your issue. And if you want to have it corrected, I think that should be an option. I will say, although it's an extremely low risk procedure, there are definitely ways to botch it.
Oh yes, like you don't
in the wrong
resect the entire labia. That is there for lubrication and protection, and like some of it needs to be left behind. So that's definitely a must.
So over resection would be probably the most common unhappy consequence of doing that. And I have seen Dr. Gary Alter, who does a lot of he just does a lot of general surgery. He's in LA. He's a urologist by trade, I believe. But anyway, he, if you're going to be known as the revision guy, you end up known as the revision guy. So he does a lot of revisions of bad cases, and he's presented, I think I've seen him present twice now, but he presented at the spring meeting for ASPS, and it was really interesting. But yeah, how he reconstructs some of these patients that have gone elsewhere. Oftentimes, not to say it's a certain group, but OBGYNs, if they're doing that, will just amputate. Really? And I'm sure it's regional depending on where you are. And also, I think if you're the type of person like Dr. Alter who only sees other mistakes, then you assume every OBGYN is doing this. You know what I mean? You're right. You're seeing a closed, you don't know what the denominator is of that, right? So at any rate, anyway, that can be very, it can cause scarring at the introitus. It can be bad. So make sure you talk to your plastic surgeon about what exactly is going to happen and what your goals are and those sorts of things, so that it's not, it's not like I'm just going to go to some med spa and, do whatever. It's important to get all that done.
Well, and a lot of patients aren't even sure of like the exact anatomy and what parts what, and they just don't really.
I know. And if you're not willing to like have that conversation, then you probably don't need the procedure. I did see somebody who was a minor not that long ago, came in with her mom, and she didn't want me to examine her. And I was like, that's fine. We can make this a fact-finding like discussion, but these are like, you have to be willing to look, to let me examine. There's just certain things. And in her case, it's just age, and there's no emergency. She can wait until she's older. But, if you're an older person and you're not willing to explore what's exactly going to happen to you, then probably not the right surgery for you. And then I did see someone with completely normal anatomy one time that was thinking that procedure would help with like sexual satisfaction. And I was like, oh no. Cause I was like, what's the issue here? And she's like, oh, I just thought, it'd give me an easier orgasm or what. I was like, nope, those are true
there's
unrelated.
There's literally, so just, you know, an anatomy refresher for those of you who may not be super familiar. So you got the labia majora, which are the outer, and that tends to have more fatty tissue, which is kind of like a nice soft pad. And then the labia minora are what we're talking about, and that's the inner part. And in people who have hypertrophy, it just means it's almost like a little butterfly wing sticking out to the side. And that's what rubs and chafes. And then you can also have ptosis of the tissue holding up the clitoris. So sometimes there may be a clitoral hood reduction if there's just, it's almost like a foreskin in guys. There's just a lot of mucosa hanging over. That's not standardly part of a labia minora reduction, but a lot of times it will do a little bit of mucosal resection there too if needed.
Yep.
So that's kind of what's involved. And mucosa is like the skin that forms lubrication, you know, like the inside of your mouth. And it's tissue that tends to heal very, very well. If you think about all the trauma those areas of the body go through, especially with childbirth and everything that entails, and things heal really, really well.
Yeah, it can take a lot. We used to do buccal mucosa, or I used to do buccal mucosa harvests for, you know, other specialties. So you take like a kind of like a square of the inside of the mouth and of that mucosa. And there was always debate, like, do you need to close it or just leave it open? Because you can put some sutures in there, but it heals so fast. It's usually healed and the sutures are in there and still bothering the patient because they can feel them on the inside of their cheek. So with labiaplasty, you do need suture.
You do, although they're generally buried, so they're under the surface of the mucosa. You don't see them. You know, I mean, maybe there might be like one external or sometimes one spits a little bit. But now, do you do wedge or do you do trim?
I trim.
Me too. This is the wedge trim debate for surgeons. Okay, so I said it's kind of like a little butterfly wing, and you can wedge out the part that sticks out, but it's really a lot simpler to just like trim off the excess. I actually learned from Dr. Furness's video, which was so phenomenal. She just goes step by step. And then I met her at ASPS, like, watched your video. They come.
Yeah.
Yay.
Yeah. Like the people who do wedges really like it and they have their reasons for doing so. I think it has a little bit higher of a learning curve. And I don't know, I think it's tougher if it doesn't go well, if there's a wound healing complication for everybody.
A little notch.
A notch, or like, if they get a sort of opening in there, a fistula rather, that can be painful,
troublesome
to correct. But I did see Sheila Nazarian had presented at the first annual Women's Plastic Surgery meeting for California Society, and she did a little talk on labiaplasty, and she's an unapologetic wedge person. She wedges, and she just like showed demos and, you know, patient videos and stuff of how she like marks and does it. And, you know, you can see in her mind, she's like, I do this, I do this, I do this, and boom, and she's done. And that's how, like, it works for her. So I think whatever is most comfortable for you and you get the results you want, then that works. And yeah, I have switched from fluorochromic, I believe, which was what somebody had taught me to do, horizontal mattress sutures that then have to fall out, to I use running 5-0 monocryl.
I still use chromic, but I do subcuticular with that. Yeah. It's actually what I do on my belly buttons for abdominoplasty too, is a subcuticular chromic, because it lasts a little bit longer. But yeah,
So do you do 5-0 or 4-0 chromic?
I think 4-0. I have to look at my OR card, but I think
I use whatever they hand me. No, I'm just kidding.
Yeah, you know, I hold out my hand and they give the suture because I made the decision 5 years ago and haven't thought about it.
I know. Nothing's worse than like deciding it, and then it's on your card, and then they ask, and you're like, I don't think about that anymore. It's whatever.
Right. Decision made, moved on. Yeah. And you know, I've had a lot of people ask me about innervation. There's a doc on Twitter, whenever the topic of labiaplasty comes on, she like pops in there to talk about innervation, because I guess she's on one of the papers, and likes to point out that we weren't really taught the specific innervation to the female anatomy in med school, which I guess the only published papers were recent. The thing is, it's like anatomically comparative to male anatomy. It's the dorsal nerve, which would innervate the penis in guys. So it's very much deeper than the superficial mucosal layer, which is all we're taking off. And that's dorsal. So you're only anywhere near it if you're doing clitoral hood reduction. And it's very superficial. You're not going down that deep in the tissue.
Hi, savvy.
So yeah, so no risk of innervation. Now, on the edge of an incision, there's always a little bit of numbness because there's a scar, but it's generally very small. And in this kind of surgery, it's not an area I think that's super sensitive.
Yeah, you don't need 2-point discrimination for sure.
By the way, that's like how far apart you can tell that there's two things versus one thing. We use it in fingers to test nerve.
Where it does matter what your 2-point
where it
discrimination.
does, because you're picking things up. But yeah, not on an area that's like ready for tough bicycle seats and horseback riding and giving birth to children.
Yeah, so I think so you think you use a running chromic, huh? Subcuticular. I like that. Not a plain gut, a chromic?
No, not a plain gut, a chromic.
Okay.
Because it lasts a little bit longer.
So again, Christine Hamori, Dr. Hamori spoke at the WPS in Tucson, and she's speaking again in the WPS remix. Anyway.
Oh, good.
She talked about.
I missed Tucson.
I know.
All the flights were canceled that weekend.
She gave a great talk, and she talked about closing. I know this is boring for everybody else but us, but Vicryl Rapide. And I was like, oh, that sounds interesting, Vicryl Rapide. And then I looked it up, and then I was like, how much? So it must be cheaper wherever she is because it was expensive. So it's like rapidly dissolving Vicryl.
Yeah, it's in our OR. One of my predecessors used to use it on facelifts, but it doesn't dissolve quite fast enough for that.
Oh.
But yeah, I mean, we have it. I've just always used chromic.
Okay, well,
which is fine.
I won't have FOMO. I was all excited, like maybe that's what I needed, and then I was like, no, I'm just doing 5-on monocryl.
I mean, if I remember it, it almost felt kind of like dental floss. It was slippier. It didn't have that braided feel that
Right. I think that's how it dissolves.
Really do you do these in the office or
I do.
Do you? I haven't made the jump yet, and I wonder. I mean, my ambulatory surgery center is literally 5 minutes down the street. So it's kind of like the hassle factor of getting gowns and drapes and a better cautery versus I can drive 5 minutes down the street.
Yeah, I have my procedure room, which should be converting to a main OR in the next, 3 to 6 months, but was set up originally to convert later down the road. So I have amazing OR lighting in there already. I have an exam chair that has stirrups. Mm-hmm. And I have a cautery machine, so I have everything I need. And do you do it under local or?
Oh, yeah, I totally do. And what I do is I just bring the topical that we use for lip filler, or half the time I forget it and I call my office and Kelly runs it down for me, which is awesome. Because I'll have it like on a Monday and I won't have been in the office since Wednesday and I'll forget. So I just put the topical on in pre-op holding, and then we give it a good 10 minutes to kick in, and it kicks in so fast to the mucosa. And then we bring them back to the OR, which is not as awkward as you'd think. Although if you've ever had a child, you're used to just people wandering around and your business all exposed, and it's okay. But we have an all-female team. There's only one male nurse at our ambulatory surgery center, and he's very rarely in my room. And we put on some tunes, and the end result is they're always like, wow, that was actually really easy and I didn't feel anything.
Yeah, they don't feel, if you put the topical numbing on, they don't feel the injection really.
Yeah.
And then again, it's really thanks. I think that as long as I think when you're doing local, as long as you slow it down, right? Like you need to, like you do stepwise, and you put the, inject the local in, then you wait, right? Because there's no rushing there. You have to make sure it's a calm environment. About half of my patients take an oral analgesic, they take an MKO, and then about half of them fall asleep during the procedure. The other half of the people are on their phone, like scrolling through TikTok or whatever, or chatting with us, because again, it's myself and my nurse, female team, and that's it. And it's pretty chill. Hi, Quinn.
Yeah, it's not bad. I have sedation privileges at the surgery center, so I'll give people like a little bit of Versed just so they can rest, but they're awake the whole time, and I'll inject the local, and then we prep and everything. You're in the Bahamas? That's not fair. I'm in Cleveland. I mean, that's lovely this time of year.
Enjoy the Bahamas. Are you at Atlantis? Because that place is bomb.
I've never been there. Is it amazing?
Yeah, it was really fun. I'd love to go again. Oh yeah, so I give them the MKO melts, which has Versed in it. And
Mm-hmm.
it messes with your sense of time. So you're like, oh, that was easy, no problem. So, but I feel like that's a good segue because we're running out of time of the next of what happens when the local wears off. Like what do you tell your patients to do post?
We have them iced in recovery a little bit, and everybody's like, "You want me to put ice on what now?" And I'm like, "No, really. It will help decrease inflammation." I also, since we have an IV in, I give them a shot of Toradol, which is an anti-inflammatory, and I do put people in Celebrex, which is
I do too.
Inflammatory. Post-op, I also do diflucan for 2 days before, 3 days after, because women know yeast infections pop up, and those can really impair healing. And then I tell them, you know, take it easy. Don't be like sitting for long periods of time without getting up. Do some ice, and I give them a little peri bottle to rinse with after they go to the bathroom, and that's pretty much it.
Yeah, we have, as usual, very similar MOs.
Which is funny. You guys should know that it's not like we train together or anything. We just happen to practice the same.
I know it is. It's funny how we like match up. We share a brain, and then luckily we're on East Coast and West Coast time, so we're able to like.
So you have access to very similar care any side of the country, guys.
That's right. Yeah, I do give diflucan. I don't make them take it. I'm on the fence about doing that. Probably should, but
well, mine get a dose of Ansep because they're in the OR, and that's kind of the scale.
Yeah, that'll mess with you. And then I tell them to take Keflex in the morning, and then that's it. They're done. And then diflucan to go home with. I use Mobit because it gets covered by insurance better than Celebrex.
Ooh, good idea.
A few, whatever, where I am, that's how it works. And then I do give them a handful of Oxy because I can never predict who's going to be like, this is no big deal, and who's going to be like, this hurts once the numbing wears off.
Yeah,
and is your friend during this, you know, ice. And the first 3 days, I tell them if they can lay flat with their butt on a pillow, that's the best way to decrease the amount of swelling that you're going to have, and so then shorten the recovery period.
It's a tough area to elevate, obviously.
Mm-hmm. It's funny because I'm going to show you something. So I always say, you know, unless you're able to stand on your head, you know, there's no way to get your pelvis above your heart. And this patient was like, oh, I do that every morning. And I'm like, oh, what? And she's like, yeah, I have this thing called Feet Up. And have you seen this?
No. Did you get one?
Whack job. So it's this thing. And I will not demo it on Instagram Live, but you.
Oh, does your head go in there?
Your head goes in there.
I think you should demo it. That
you
would
can do.
It kind of looks like a birthing stool from that.
It does, but you can do headstands, and it helps you practice headstands and maneuvers. When I first got it, we screwed around a lot with it. I do not do it every morning. My daughter, who can do a handstand, we were doing like combo things on there. It was funny. So anyway, it's called Feet Up. I don't make my patients do that post-operatively, but that would be really the only realistic way to get the swelling to go down.
Yeah, unless you're like, you know, if you have like an OR bed and you're in like some Trendelli, but then all the blood rushes to your head, it's not very comfy.
Yeah, and you can't stay upside down like that for a long time either.
It's hard on your brain vasculature. Yeah.
But I totally learned it from one of my labiaplasty patients. I was like, oh, what? What are you talking about?
This is how I elevate. Thank you, Dr. Gallus. That's awesome. And then, of course, I always tell my patients, no riding a bicycle, no riding a horse, no intercourse for 4 weeks. Let things heal.
Mm-hmm. Yeah, no tampons.
Oh, yeah, I forget that one, but yeah.
No menstrual cup, whatever. Nothing for 4 weeks. Yep.
It's nice. My nurse educator has had the procedure, so she's like giving my patients very thorough instructions.
That's good. Yeah, so I do, we have a little packet. Actually, when I see the patient for the consult, I give them that pre and post, because the next time I see them, they're scheduling it. I'm like, these are all the things you need to know.
Yeah.
What's involved. You're going to need ice, have all this stuff ready to go, and then it makes it smooth sailing. And I do a fair amount of like local healthcare providers because, again, I'm a woman. So if you're an OR tech in another facility, you're like, I'm not going to have my male plastic surgeon do this. Mm-hmm. So I'll do it. And those patients universally are terrible at staying off their feet.
Are we terrible?
Yes, we are all terrible.
Oh my
so
gosh.
back to work like day 2, and then like it's really swollen. Yeah.
I don't understand. My mom was not yelling at me yesterday, but I was talking about how I should really rest this weekend because I was sick, and I'm like, oh, the kids are with their dads, I can rest. Yeah, I was like out cutting down shrubs because the wood chipper guy was coming on our street today. I didn't rest very well.
No, we're not good at that.
No.
I need the Bahamas resting, Quinn, but he's
Yeah, I mean, we should do that. That could be like an educational trip.
Yeah, we should do Instagram Live from the Bahamas.
God, that would be amazing. I was hoping we could do it from Tucson, and then every flight in Cleveland gets canceled.
I know. Next year, Charleston. We'll figure it out.
Ooh, sure. That'll be fun. Yeah. And I'll be in WPS Remix. That'll be fun. I'm going to get a babysitter so my kids don't photobomb. Because when I did the WPS presentation, I had Sawyer on my lap, and she's like getting all the comments and waves. And I'm like, questions? No?
Yeah. Oh, yeah, that'll be great. I know. People were really, they wanted to see, well, because we didn't have enough time for your whole talk.
So I didn't have pictures.
Access to the whole talk. And yeah, and you can give us new content. It's going to be awesome. These are going to be good. So, all right. Well, what are we going to talk about next time? Are we going to do breast mesh? Because I feel like it's trending again.
Because it's awesome. I use a ton of Galliflex. Rob, my rep, if you're watching this.
Yeah, the Quinn is.
Yeah, we haven't talked to.
We can talk about it, like the indications. So one of my patients sent me some stuff where people are like, well, with 700 cc implants, I can, and mesh. And I'm like, let's talk about what you can and cannot accomplish with mesh.
Yeah, I like to save that more for, I have 700 cc implants and they've fallen into my armpits. Now what?
Right.
That's that. I did use it for a capsulorrhaphy, though. They had really laterized and it's holding.
It does not move. Yeah.
Okay, so we could talk about mesh next time. There's a couple new ones on the market. I don't know anything.
Yeah.
About
I know about one of them, and then I've heard about both of them. So yeah.
I feel like we should be getting corporate sponsors for these talks, especially the ones where we're talking about products. Like I would like a Galliflex baseball cap or something.
We want merch.
Yeah. Yes. Tote bag. I mean, that'd be great. But if you guys have any topics you want to hear about, throw them in the comments.
Please, yeah.
Of us.
Yeah. Let us know. All right.
Sure.
All right. Well, we'll regroup and figure out when we're doing this again.
Perfect. Fun seeing you.
Yeah, it was good to see you.
Bye.
Bye.